Anyway, probably none of you have had to deal with STDs like HPV in the past. Psych, I'm just kidding, actually. It's one of our most common problems that we experience in our clinic for having folks come in and be anxious about it. It certainly is the most common sexually transmitted condition globally. I used to sort of struggle a little bit when they would say that chlamydia was the most common because we were all seeing warts for forever, and I really thought that there would be more research going on earlier. With the advent of HIV, though, and AIDS in the early 80s, most of the research dollars sort of went towards that instead of HPV. So we're catching up on that now. It's estimated that between 50 and 80%, it depends what study you look at in terms of how many people actually have been exposed to this and contracted it. The British say 100%. So we know that it's very common.
I'm so sorry, I'm going to have you move the mic just a little bit higher. It's a little bit quiet. Yeah, let's try that. Sorry.
Okay. And the peak prevalence tends to be when people begin having sex for some reason. So we know now that these infections resolve spontaneously. Years ago, we actually thought that if we eradicated the bumps, people were cured because we didn't know about all the multiple types that were involved, and we were only aware of the bump kind of warts. Anyway, my goal for this evening is for you to understand a lot of the biology about HPV. We'll talk about the epidemiology about it a little bit, the natural history of it, screening for pathology that's associated with these infections. We'll look at the clinical presentations of external genital warts, and we'll look at a number of things that are sometimes mistaken for warts, but that actually are not warts. People are getting a lot more savvy about genital dermatology now, fortunately, but it still is possible for some clinical staff and certainly for most patients to mistake the bumps that they are seeing for warts when they're actually not. And we'll talk about management and touch on prevention, although your next speaker will be talking about immunization, which is the main means of prevention of the majority of pathology associated with these organisms. Human papillomaviruses are DNA viruses. They infect different areas of skin. There are between 120 and 150 that have been identified, and there are certainly going to be more than that that are identified over time. Just as I can identify multiple types of bacteria, just technology is continuing to grow in terms of identification. They really tend to like specific areas, just as certain bacteria tend to like specific areas. Type 1 is plantar's wart and tends to generally be on the sole of the foot. Type 5 tends to make most hand warts. This is just arcane, interesting information. And we know that there are specific genital types as well. They generally don't circulate in blood, although there have been some studies that indicate that they've been able to find DNA of these organisms in blood and plasma. But I'll talk about why that's not too much of a concern in general as we go over more of the genetic specifics of these organisms. The main types, and please don't write these down, are type 6 and 11. And generally they're almost never associated with cancers. Now, people can have cancers and have these organisms, but that's generally because you can have more than one kind of HPV at a time. Having one type doesn't mean that you wouldn't be exposed to others, and in fact, the more partners that people have and the more mixing that occurs, the more likelihood of having multiple types that people acquire. Low-grade lesions are caused by these. Here that we can see are high-grade. The majority of pathology is caused by type 16 and 18, which again is just interesting and data to have in mind. But when you get your Pap tests back, they're generally not going to type down as specifically to say you have type 42 and type 81 and type 61 and type 16. We just know that these are associated with the greatest number of pathologic organisms. And the reason that's important is because the vaccines are targeted for these specific wart viruses and are very, very effective. So this is what I think is very interesting. We're going to talk a little bit about the HPV genome so that you understand why, especially the type 16 and 18 cause problems, and the others are less likely to do so. We can see here, and I should have brought my pointer, but in any case, you can see these different little numbers here. The E stands for the early genetic manifestations of the organism as it develops and grows. And we can see that different areas do different things. The E1 is responsible for encouraging this to form episomes which can replicate rapidly inside of epithelial cells. And then you've got growth stimulation and other things. Our concern is that there are certain parts of this organism, once it's been integrated into host DNA for these high-risk types, that shuts off the cell's innate ability to self-destruct. Most cells undergo something called apoptosis, which is a normal and natural cell death. If we have these organisms in here and they've integrated their genetic material into the cell, and the E6 and E7 have modified the host cell so that it won't expire as it should, then we can have continued growth of that cell, which isn't a problem unless there's some other genetic deformity that occurs that results in atypical growth. Oh, talk into here? Okay, I'll talk into here.
Quiet in the back.
Okay. So these actually infect the basal layer of the epithelium, and most of them actually remain latent and just kind of hanging out. Some begin to replicate. Most people who acquire these infections don't even know that they have it, because the majority of these don't make bumps. The majority of bumps are caused, again, by type 6 and 11. We also know it's interesting how this has sort of evolved over time. When I first started working in about 1980 in STDs, we believed that once we eliminated the bumps, that people were cured. And so part of my sort of getting the name of the wart queen, as dubious as that is, was because I was terribly afraid of missing some of these and having somebody leave thinking that they were cured when they were in fact not. And then as the 80s progressed, they were saying, oh my gosh, we've sampled areas that are 2 or 3 or 4 centimeters from the initial lesion that we can see, and there's virus DNA there. And as time went on, they said, oh my gosh, it's persisting. It's forever, like herpes, which was a little bit terrifying to us. And now, as people have been followed out longitudinally over years and years and years, they've been able to say the majority of people actually do either suppress this and have it end up being latent or eradicated. I prefer to think in terms of latency rather than actual eradication, although it'd be nice to think eradication. So this is just an image of the epidermis that we can see. The stratum corneum that we all know about. We've got the stratum lucidum, the stratum granulosum, the spinous layer, and then we get to the basal layer down here. And that lower layer is where the organism actually enters and begins its replication cycle. This is just a little bit more crude drawing, but it's a little easier to interpret and integrate into our sort of visual image system. This is a really nice, you could actually go to this site, they're great. They gave permission for us to use these images, but we can see that there is a trauma to the epithelium here, and you can see the HPV organism entering in this just very thin layer of epidermis and getting down to the basal layer here where it integrates into the cell. the virus itself on the external capsid of it, actually with the L1 and L2 parts of its genetic structure, which make up the capsid essentially, has a protein there that actually interacts with the host cell, just as we know HIV has target receptor sites for specific lymphocyte cells. So does the HPV organism. So these proteins attach to the epithelial cell and allow for entrance and actually uptake of the organism into the cell. Once it's there, then it disintegrates itself and begins the replication process, or remains as a virus, because it's not like just one enters one cell. We're looking at numbers of organisms. This is just simplified so that we can see it a bit more clearly. So you can see that it's broken apart down here into the cell there, and then the little circle represents the episomes, an episomal form that will continue to replicate. And I don't know if any of you guys have noticed that areas of trauma and the areas where warts generally show up the most tend to be areas that have been abraded or are more likely to have friction during intercourse or masturbation or aggressive scrubbing with anything, a loofah, whatever. So here's another image of this, and we can see that the basal epithelial cell has now got these episomal forms that are replicating and replicating and replicating. At each layer of the epithelial cell here, we can see the E1 and E2 here that's established some latent infection, and now here it's growing and multiplying. At each stage, it becomes a bit more mature, but the episomal forms of this are not infectious. It really has to have matured to the point where it's got a full capsid. So when I'm explaining this to patients, I say it's a little bit like, because I think in simple terms, sort of like an insect. A mature form flies around or crawls around, does whatever it does, finds its specific host plant, if we're thinking about herbivore sorts of insects, lays an egg, which would be the entry into these epithelial cells. The egg hatches and you've got an immature form, sort of a larval form. These really aren't larvae that are mobile or anything, but in terms of just not being infectious, a caterpillar or a larval form of any insect isn't capable of reproduction because it hasn't matured and undergone its metamorphosis. And so these really are immature forms that allow for replication and then allow, as the late genetic portions of the virus activate for integration and capsid formation. And at that point, these are fully reproductive organisms ready to be massaged into a new host in one form or another. What makes the vaccine so effective is that they've learned through essentially DNA amplification that antibodies specifically target the L1 and L2 parts which form the capsid of the virus. That's why the vaccinations are empty capsids. They don't have any genetic potential for reproduction, but they're a capsid form that is indistinguishable to the immune system from the real virus. And if we can eliminate those areas and the antibodies attack them, they cannot attach to the cell and be integrated in. So you can't establish infection even though you've been inoculated. So again, just an image of this occurring. So now we've got an intact virus. We've got disrupted cell proliferation as well because of the genome and genetic material of the virus here. As it grows, latent viruses we can see as the purple or blue spheres and the episomal forms rising up, integrating and becoming intact infectious viruses. How does this occur? It's actually skin-to-skin contact. And why is that? Because the virus is in skin cells. It's not in body fluids. So it's not something that's transmitted through fluid transmission. It's actually skin to skin, acquiring epithelial cells that have infectious viruses in them, or acquiring free viruses that have been released from these cells. And the way to transmit those cells is generally from skin to skin or hand to hand. And we actually have been able to find that there are viruses of these certainly high-risk types and others that can actually reside on fingers and hands, which is sort of interesting and new as well, or relatively new. We can see this in people who've never had genital intercourse, and it's been found, and sometimes that's because of maternal transmission, sometimes that may be because of hand transmission, other things. Vertical transmission is rare, again, because this isn't a serologic or an amniotic fluid-borne condition. It's a epithelial transmission. There's some question about fomite transmission, and I don't know that there's any ethical way to try to determine just how well that works. But certainly sex toys and things that could have epithelial cells on them that could be massaged into other susceptible skin sites would potentially share this. So the peak prevalence, again, occurs during adolescence and young adulthood. And why is that? Because people enter the hormonal state of Y&D, and Y&D means young and dumb. How do we get old and wise? We survive young and dumb, but there's a lot of bio baggage that can be picked up along the way. So again, most of these resolve or are suppressed. I usually tell people it's the same thing with herpes, that just like chicken pox, although now most kids haven't had chicken pox, but it remains latent and it can reactivate or be a problem. But mostly it's just bio baggage that we cart along without any kind of problem. The Centers for Disease Control says, well, at least 80% of sexually active adults ultimately will have been exposed to this over time. And generally when we get people that have pap smear problems, it's not from new acquisition, it's from reactivation of old prior acquisitions. The estimated lifetime risk, again, this is a little redundant for time purposes. I'm going to go ahead and just go past this. But we can see that there's a lot of genital acquisition. Genital warts, not so much. Because not all people that acquire type 6 or 11 are necessarily bump makers either. There's a lot to do with host immunity. Abnormal pap smears over the course of acquisition of these things, more than a third, most of which resolve, which is again why they've changed the pap recommendations. Invasive cervical cancer, which is a significant problem in areas without routine pap smears, it's around 3%. Regular paps reduce that down to about 1% of women getting screened having invasive cervical cancer. Other cancers are about the same, although anal cancers in men who have sex with men approaches that of females who have not had access to pap smears. We're going to talk about anal paps because it's really a big concern and a point of a lot of debate, even among experts still. We've seen increasing rates of head and neck cancers as a result of particularly HPV-16 that have been noted over the last 20 years or so as well. HPV infection in young women following onset of sexual activity. Rachel Weiner actually did a study some time ago, and we can see that by the time people had had 3 partners or more, the incidence of HPV acquisition was extremely high. Some studies have said that by the time people have had 4 partners, there's an 80% probability that HPV acquisition has occurred. And this means that just about everybody outside of this room has been exposed to HPV. So when they looked at young males in the university system, they found that of all of the types that they could test for at the time, the cumulative 24-month incidence was 62%. That's a pretty high incidence. Now, of that 62%, 50% were high-risk types. And high-risk types tend to stay longer, again, because of their ability to modify the genetic components of the epithelial cell. So it's thought that 90% or more of these actually will clear within 18 to 24 months. Most pathologic lesions will occur because of long-term persistent HPV infection. The natural history, again, when they followed these young women, 70% actually appeared to be clear within 12 months of follow-up after their incident HPV infection in terms of the DNA tests that they were doing at the time. And in 2003, they found that most low-grade cervical lesions spontaneously regressed, but approximately 10 to 13% persisted and progressed. So this is a little bit of a busy slide, my apologies, but we can see that we have an initial infection here, some of which promptly go on to CIN, most of which don't, and even CIN can actually regress. Some people go on and have persistent infection, which then can lead to CIN 2 or 3 and thus to cervical cancer. The majority of individuals don't. Again, if we look at 80% prevalence rates, if everybody that had this was going to go on and develop pathology, we'd have a lot of cervical cancer. And we don't, but it is a preventable condition. And so are these head and neck cancers that are beginning to increase. But again, the majority clear. And you can see that even CIN 2 and 3 can regress and involute and appear to be resolved. This is a really busy picture, and you've got it in your handouts. But we can see that when people have gotten low-risk HPV, it can kind of bounce around, but it returns and it doesn't tend to become cancerous. When we look at high-risk types, much greater risk of cancer, all of which still can bounce around and come back and be okay. And this is included because it's just 5 or 6 years old as opposed to the 10-year-old study. So in multiple studies, however, type 16 is the one that persists the longest and is involved with the most pathology. Type 6 and 11, the bump kind, and type 84 had the shortest means of duration, lasting only about a year for most individuals. Now, not all, of course, and this is a very busy slide that's just included for interest. So it's in your handouts and you can look at it, but basically it sort of tells you how long most of these tended to last. The incidence of SIL among women with incident HPV infections, 3-year incident was about 40. With a median induction of about 4 months. CIN 2 and 3 in these 600 young women was 11 at 14 months, and with type 6 or 11, the induction was very short actually. Usually it averaged out to 3 months, but I'm sure that you guys have seen people that have developed bump warts within a month or so after contact with someone, and people who have developed their bump warts when they haven't been sexually active for over a year. So there's a lot of variability, and a lot of it has to do with the integrity and health of the epithelium to begin with. So the highest risk ones, again, are found in 50 to 80% and up to 90% of invasive cancers. Other types, 31, the ones that are listed here at the bottom of the slide, should still also be considered carcinogenic. But this is still a little bit esoteric because it's not like we can test for these and get a test back routinely. These are tested for in pap smears that are obtained through the liquid-based pap and sent off for screening that way. Lesions of the cervix, we can't always visualize them effectively either, so it is important when we're doing PAPs to obtain good samples. This is Claire Stevens' image from the 80s. We can see cervix at the top with just that faint little bit of, it's not really overt leukoplakia, but it looks a little bit different down at the bottom part of the cervix, and with acetic acid application and colposcopy we can well, this is even without colposcopy, you can certainly see that there's a significant amount of abnormal tissue. This one really scares me because this was a 36-year-old woman, a British woman, who was classified as L-SIL, and the thin prep past was interpreted as reactive changes prior to the advent of DNA typing for HPV. 18 months later, obviously she didn't come back after 3 months for any kind of rescreen. We see these warty growths, but they were actually carcinoma. And it was invasive squamous cell carcinoma. In our clinic, we don't ever treat cervical warts, we observe them. And it seems like we're seeing fewer and fewer cervical warts. We do have people come back with abnormal pap smears more. Little visual rest, especially since you've had supper. So, continuing on, the guidelines for cervical cancer screening, who should be screened? We can see some abnormal lesions here. Again, we want to check for things because most of these involute and become okay, but here we can see a pap smear progression. So we have a healthy epithelial cell to begin with, the basal layer along the bottom. I put these little arrows on just to kind of keep a continuum here. We have infection occurring, introduction and replication of the virus, the larger purple circles that we can see here. And we can see episomal development and then integration and more shedding out here. And because of this being a high-risk type of organism, it's actually integrated into the DNA of the epithelial cell. Some abnormal genetic occurrences have developed and persisted, and we can see now that we've got grade 1 or L-SIL and then grade 2, and we've got grade 3 and then invasive cancer because this has progressed and the genetic abnormality has amplified and persisted and morphed even more. We all actually have little cancers growing in our bodies all the time because our DNA isn't always perfect, but these cells generally don't persist. And so most of the time people remain okay. It's just that with these particular cells and their lack of undergoing apoptosis, progression is more likely to occur than it normally would. If these little genetic abnormalities were occurring in the absence of this particular organism with the E6 and E7 turning off that your time is up gene, then they would have died on their own. So we all know about the pap smear changes. Are all of you guys familiar with the 2012 pap smear guidelines? Exactly. So finally everybody, all three organizations agreed on what pap smears should, how they should be done and how often they should be taken. So everyone agreed that it should now be pap at age 21 and not before, regardless of age of sexual debut, where before it was age 21 or 3 years following the onset of sexual debut. From 21 through 29, now they're saying every 3 years, but how many of you guys really like that? Gosh, it's funny. It's recommended and everybody's agreed on it from the higher ups, and all of us go, gosh, that just feels so wrong. The cynic in me says, it means that insurance companies don't have to pay for it then, you know, for another 2 years. But, you know, that's insurance in America. But in any case, that's the current recommendation. So when you're doing your pap smears, make sure that you get a good one. Women can sort of do their own checks too if they were going to be feeling anything abnormal, just like they can do breast exams, but a pap smear is really the best. Women ages 30 through 65 can be screened every 3 years still, because that's when most cervical cancers are going to develop. Usually not in the 20s, although all of us have anecdotal patients who have developed high-grade, rapidly progressing cervical cancer lesions in their 20s. It's not the norm and it's not the majority of individuals, so that's how I think how they're justifying the delay in repapping. So they're saying that you can screen every 5 years now with the HPV co-testing and liquid-based PAPs. How many of you guys have access to liquid-based PAPs? Most people, but not always, all of them. In our clinic at Harborview, the public health clinic, we don't have the funds to be able to do liquid-based PAPs. So we do the best PAPs that we can and send them off, but we aren't able to do HPV testing or liquid-based PAPs. So the suggestion is that you do these co-tests with women age 30 and older, because most of the infections are going to be transient in people's youth, and most people are going to end up being okay. In older women, HPV infections have generally been more persistent, and that's typically when most cervical lesions are going to be progressing. So again, we do recommend HPV co-testing for women who are over 30. I actually have a friend who has been with her husband only for years and years and years, and to her knowledge, he's only been with her, and she developed high-grade SIN at age 37 with no specific risk factors that she was aware of, and ended up having to have a LEAP. Women with certain risk factors, high risk for progression, HIV infection, immunosuppressants. We know this, DES babies, although DES babies mostly were in the 50s and 60s, and we don't see a lot of women who've been exposed to DES at this point. I'm nearly 60, and most of the DES babies were born before my time, so the likelihood that you're actually going to see somebody with one of those malformations who's just now developing cervical cancer is pretty low. So women who've had a hysterectomy don't need to have a cervical pap smear because they don't have a cervix anymore and the transformation zone isn't there. One of the issues here, we don't have good statistics on what VIN is, how common vulvar intraepithelial neoplasia is, and we don't see a lot of vulvar cancer. Occasionally I've seen one case of a vulvar melanoma, but that wasn't HPV related. So basically women are off the hook to a great degree if they don't have a uterus or cervix. Basically with HPV testing and being done with women with ascus paps is that if the HPV test is negative and somebody has an abnormal pap smear, the likelihood of them progressing to a high-grade lesion or overt cancer is really profoundly low. Certainly if they have an abnormal pap smear and they have high-risk types, then further follow-up is definitely warranted and indicated. So May of 2008 said negative pap without HPV testing after ascus is associated with significant false negative results, and part of that is due to sampling issues. If people are in a hurry, when I have students, I really encourage them to be a little bit aggressive getting those cervical cells. You know, and you can tell women that it's going to feel crampy. I tell people it's going to make your toes curl because it's gross and obnoxious. And the endocervical sampling feels a bit like a period cramp, and I usually have them breathe through it, take a breath in and blow out as I'm doing that rotation with the cyto brush, and then it's done. Gives them something to do, and it lets us really be obsessive about getting good samples, because it would be a shame if you didn't obtain an excellent sample. A negative pap smear without HPV testing after ascus, again, we had said that. This was a study of 149 women who had sex with women using a DNA amplification test, and they found that it was pretty much the same as women who had sex with men. There's been a sense that women who have sex with women don't need screening to the same degree because they're not going to be exposed to these organisms. But when you look at an overall prevalence rate that's as high as it is now, women who have sex with women are still at risk for this, and certainly still need prevention messages and routine pap smears. Jeannie Marazzo, how many of you guys are familiar with Jeannie? Just a few, but some. They were following women for a long time and found that 80% of these women had reported that they'd had sex with a man at some time. And they compared the presence of high-risk HPV and found that about 1 out of 5 had high-risk HPV. When they looked at women overall, they found that 14% of them had evidence of SIL. So again, we do want to go ahead and screen women who have sex with women. The big issue for us, I think, isn't so much should we screen women who have sex with women so much as it is should we screen and how do we screen men who have sex with men. But the thing to remember basically with cervical lesions is that they mostly are transient and most of them regress and people end up being fine. Pap smears do reduce the likelihood of invasive cervical cancer and death as a result. What about other anatomic sites? No visible oral warts, but I like this, his hand on his throat. Michael Douglas lived through stage 4. That's really surprising to me. In the past, most head and neck cancers, most oral cancers, occurred on the gingival margins and on the buccal mucosa where people tucked their chewing tobacco and kept it there, and it caused tissue trauma and tissue irritation, and the carcinogens in the tobacco encouraged growth there of these cancerous lesions. What's been happening more is that there's a shift, an earlier shift to oral cancers among younger individuals. When people were chewing tobacco extensively, those lesions would occur into the 5th, 6th, 7th decade of life, and with the increase of these other things, they're showing up in younger individuals. So it looks like it mostly occurs in the tonsillar area. I did have a guy who had come in from his dentist who said, the dentist said, it looks like I have a wart on my hangy down thing in the back of my mouth, his uvula. And he said, you know, I need you to check it, and he said somebody needs to take it off. Well, that's not something we can do in our office, but I could look at it. He had a particularly long uvula, so it took a little bit of trying to actually be able to visualize it, but sure enough, on the very end of it, he had a warty growth. So he was really frustrated that we weren't going to be able to just freeze that or take it off. But generally when these occur, they do need to be removed and have cytology run on them. People who don't have tonsils still can get lesions on where the tonsils were. And you might notice that when you've been to the dentist, he's checking your lymph nodes and really looking around more than just checking the x-rays and going with the cleaning now, and that's because they're seeing more and more of these, although the rates are still pretty low. So prevention, you'll be hearing about HPV vaccine, but I must say that it works. It really, really works. Again, because it helps the body develop antibodies to those the capsid proteins on the virus. And once your immune system is aware of those and recognizes those, then that would and they attach to the organism to modify it, or just it makes it unable to be incorporated into the cells. So that's again why it's so effective. In terms of patient education, sex is sex, regardless of what certain presidents might think. And it's important to remember that it's very, very common. Again, you know, if you think that most everybody's been exposed to this and most people are doing fine, I actually sort of equate it, because it sounds scary, it's the new, well, we can't say it's the scarlet letter. What's the scarlet letter? Herpes. But people aren't worried about herpes now because they can get medication and walk along the beach hand in hand in a romantic way like we see on TV, right? So while people, and it's so prevalent that people don't really freak out about it, but again, because we have word association in our culture, and if we say cancer, our brain says dead. If you say, oh, you might have a little prostate irritation to a guy, they go prostate, cancer, dead. Now you say HPV and they go, HPV, cancer, dead. So everybody's freaked out about it. Everybody's freaked out about it. Healthcare providers are freaked out about it, but patients are really freaked out about it, and we really need to reassure them. If we checked everybody in this room for staph for MRSA, some of us are going to have MRSA, but we're not testing for MRSA. We treat the pathology that occurs as a result of having that infection. So I sort of call HPV biobaggage. And while I don't want to minimize the pathology that's associated with it, I do want to make it a little bit less scary in general, so that people know that they can be screened for it, also so that people can know that it's as prevalent as it is, and that it doesn't always take, you know, fully doing the deed. Very, very important. Mucous membranes in the oral cavity are similar to genital mucosa, and hence the increase in transmission there. When I started working in the STD clinic, having grown up a very pure Baptist and being told that we should never even kiss a man unless we were going to marry them, and believing it, it was a little challenging for me to start to ask women if they had oral sex. But gonorrhea rates in the 70s and the early 80s were pretty high, and we were checking for gonorrhea at all exposed sites. So I could say, have you had oral sex, so we should take a throat culture? And many of them would say, oh no. Some of them would say, no, but you can test anyway. And the same thing with anal contact, you know? They'd go, oh no. But some would say, but can you test? So that behavior did occur. Now it's actually becoming a norm for young people. There are lots of changes that are occurring in the sexual repertoires of younger individuals. So just as we can see that men who have sex with men is becoming a norm, and it's being accepted, and I think that it should be. Partly because my brother's gay, and he has had a partner for, golly, over 20 years until Ken died. And it was a normal, loving, caring relationship. But there's also changes now with poly folks. How many of you guys have heard of the poly groups, polyamorous groups? It's becoming more and more the norm for people to have open relationships, even in heterosexual couples. And there are the queer groups. Now, when I was a kid, queer was an epithet, like saying the N-word. But now queer is embraced as sort of anything goes, as long as you decide what kind of relationship that you want to have. So there's a lot more transmission of these organisms, and it's much more widespread than it was in the past. Sex is really commercialized on TV, so it's become a norm for kids to see all kinds of this stuff. And the next generation is going to find that this is just the way that life is, where we'll be going, huh? And they'll go, you're just old. You don't understand. So kids do need to know that there is a likelihood that they're going to be acquiring these things from these sorts of intimate contacts. I had a young girl in this week, just stunningly lovely, and she was talking about her fiance who also has warts. She has anal warts, perianal warts that we've been treating, and she said that it really has made her reconsider her sort of cavalier feelings and thoughts about multiple sexual partners, because she liked the idea of being polyamorous. Her partner had not been into polyamorous contacts prior to being with her, but they've been together now for 2.5 years, and he's really interested now, and because he's like 24, 25, and she's feeling confused about what she thinks about this now, because she's manifesting the bump kinds of warts. It's really changed her thought about things. But it's a little like being pregnant. People don't think they can get pregnant until they are as well. Speaking of anal warts, anal cancers. Anal cancer is a big issue. We worry about it in MSM. Far more women develop anal cancers than men do. Possibly some of those women who were okay for being cultured long, long ago. And partially because when women are counseled about wiping, following, using the toilet, how are they supposed to wipe? Front to back. So if they're really diligent and they wipe the vulva and go back and scrub around the anus, anything that's been frontwards has been swept backwards and massaged in there as they wipe the last little bit, they hope, of material from back there. So that certainly can introduce sloughed epithelial cells and massage them into a susceptible site. It certainly is much less common than colon cancer. It got a lot of news because of Farrah Fawcett years ago. Now it's the head and neck thing with Michael Douglas. Pap smears remain a huge focus of debate on this, and I myself actually have to confess to having mixed feelings about it. The party line among infectious disease docs, among people at the Centers for Disease Control, among people at our Madison clinic, the AIDS clinic, and the research clinics, is that routine pap smears shouldn't be done on males, men who have sex with men, because nobody knows what to do with them. And indeed, they've had consult calls coming in going, gosh, we did this pap smear on this guy, and it came back SIN 1 or SIN 2, and their response is internally, well, why'd you even do one? Well, because of the cancer risk. And in fact, there aren't any standard guidelines as to how to obtain a sample. Right now, the standard guideline is sort of a blind swab that you roll on a slide and hope for the best. And we had a gentleman out for one of our AIDS clinical conferences who was discussing this, and I said, well, why wouldn't you do even a bit of a prep like you would for a colonoscopy? Couldn't somebody do like a Fleets, or could they do, you know, one of the osmotic enemas, or things, kind of clear things out? So, or could you just not obtain it with an anoscope so that you'd actually be looking at where you were going to take the sample? And it's no, 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 no. So if something comes back and it's got too much fecal material or other stuff obscuring, then you have to repeat it and redo it. And then even when that happens, nobody knows what to do with it. David Abalafia at Virginia Mason in Seattle actually has a colposcopy clinic where they have been following people who have had pap smears and had them done and had abnormal ones. But you can't do a LEAP procedure on an anus. One expert had recommended a DRE to look for fixed masses, but even that wouldn't necessarily tell you, and certainly things would be pretty far gone by the time that you got there. But I think that it is prudent to keep an eye on men who have sex with men, do an anal exam, and while you're doing it, do an STD screening, do a syphilis test. We're having lots and lots of syphilis. I had to insert that because we see so much. But do inform people, and you may elect to do a careful external exam and look for things. You may elect to do anoscopies. I think that it's probably going to be 5 or 6 more years before there's really a consensus about the best way to manage these. And yet the incidence of 3%, again, which rivals that of unpapped women, is unacceptable. It's true that 97% of guys then roughly would be okay, but we don't know who the 3% is, and that's 100% to them. So keep your ears open. We'll have some guidance and consensus, hopefully, because the researchers and other folks aren't necessarily like our political parties that are in constant opposition. Hopefully we'll get some data, and they really are studying this just to sort of see what the best way to go is. Risk factors, obviously, a current HPV infection, a history of receptive anal intercourse, and certainly that's going to be the thing that's going to introduce these organisms further up in. Generally, materials coming out, so since these are not mobile organisms, they shouldn't be entering in. So that might be something that is worth discussing with patients early on when they're beginning their sort of sexual practices. So, am I going backwards? What happened here? So, genital warts. What about genital warts? Well, the condyloma acuminata, the bump kinds again, are generally type 6 and 11, and they tend to occur mostly on external genital skin surfaces, although not always. They can be different shapes, different morphologies. I particularly like to treat the pedunculated cauliflower types of warts because they respond so nicely to liquid nitrogen therapy. The patient's really happy, and I feel like I've really done a good job. But and some of them are a little bit more challenging to try and eradicate. But all these different appearances, generally the 6 and 11 tend to be a little bit more exuberant and exophytic. And they tend to be in areas where there's a lot more likelihood of skin scraping, skin trauma, skin abrasion, anything, and unhealthy skin. Somebody that's got sort of imminent lichen sclerosis, atrophicis, sometimes will present with warts because the skin is so abnormal, it's trying to heal, and in that healing phase, it's releasing substances, hormones. Actually, it's called, I'm trying to remember, can't remember the terms for the specific hormones that are released at that time that really encourage cell proliferation and also entry of HPV organisms. They can occur in different places. In the urethra, I look for urethral warts when I'm looking for urethral discharge, not obsessively, but just as a glance over. We do recommend that acetic acid not be used for screening for external genital warts, and the reason for that is that epithelium is made of keratin, just like fingernails, just like hair. It's hydrophilic, so it absorbs moisture. And if you think about what your skin would do as a little kid, if you had a scrape on your knee and a Band-Aid over it and you were soaking and playing with bathtub toys and you got out and the Band-Aid had come off, what did the skin look like where the Band-Aid had been? White and fluffy. So with prolonged acetic acid application, sometimes if there's a wart, it will actually develop acetowhitening. It's true. But other areas that might have been scratched or excoriated or irritated for one reason or another can become can experience acetowhitening as well. And when one of the researchers, gosh, way back in the 80s, was doing tissue samples of areas that had developed acetowhitening, they found that as many samples didn't have HPV as did have HPV. So if you've got a 50% sensitivity, specificity, that's not a really very good test and it takes a long time. Whereas on a mucous membrane, it works very effectively. So we do recommend it for colposcopy. Do use a good light source. If you're really looking, careful evaluation, you can kind of train your eye to see changes in things. I usually use a Q-tip when I'm doing an exam for a couple of different reasons. It lets me move tissues delicately and I can see around it. It's smaller even than a pen, which is smaller than my finger, and because it's less nerve-wracking for the patient. If I say, I'll wave it around at them, I'll say, I'm going to be doing a little exam, you're going to feel a Q-tip down here as I'm just moving tissues. So they associate most of the manipulation that's occurring on the skin there with the Q-tip, even though you may be using a hand to stabilize skin as you move things around. These are some subtle warts that you can see here, these small dome-shaped papules. And it looks to me like this person has actually had some prior treatment because you can see that sort of paler area, that little row along the top and then a pale area. Sometimes you'll see folks that have had cryo done and warts growing up around the margins and edges of the treated area. And again, that's because these cells are trying to heal. We've got those growth hormones released to try and cause healing and integration of the organism and replication and new wart formation. So it really is okay if you're going to be using cryo to freeze a millimeter or two around the outside of that wart. It's not going to be causing any undue harm. And it's really important that you freeze to a great enough depth to achieve a therapeutic response. Because if you just freeze the top of the bump that you can see, you haven't gotten down to the basal layer. It's just going to grow back. And it's important to tell patients about this as well, because the patients will look down and go, ah, it's going away. Well, it's not going away, it's just smaller and it'll grow back. So we really want them to be adequately informed, and we want to be able to do adequate treatments. These are really classic warts, very, very gratifying to freeze because they really respond so nicely. The reason they have this stippled appearance is that they've got lots and lots of capillary formation in there. And when you've done your freeze on the active growing top part that you can see, you get a lot of swelling, which causes constriction of the blood vessels, which eliminates any ability to heal properly. So the part that you've frozen at the top just responds, it dies. That's what we want to have happen. So, pretty gnarly looking ones. This is what you use in school health projects to scare kids. A couple more here on the vulva. A little visual rest. And a couple of more. These are a little worrisome, but certainly we would treat these very effectively with our cryo. I tend to prefer cryo because we've got it available. For those of you that don't, the typical TCA, BCA methods are effective as well. What about anal warts, perianal warts? It's worth doing an exam. If you have MSM who are coming into you for screening, please don't just get a urine sample, because that's not the most common site of infection. How many of you guys know the most common kind of sex that men who have sex with men is? Oral. That's absolutely correct. That's absolutely correct. So throat cultures and throat swabs for STDs are important, as are anal samples, and asking about what kinds of sexual practices people are engaging in. So urethral warts sometimes can cause a split stream. Urinary passage is occluded by these, and it can affect the flow of urine. These can be treated with the same things that you would use to treat vulvar warts, as long as they're at the distal area here. When they end up being further up into the urethra, then you can actually reasonably treat either with cryo or something else. Then 5-fluorouracil is something that's often used for that, or waiting to see if they will involute on their own. This is an oral lesion in a man who has sex with men. The differential diagnosis, molluscum, molluscum contagiosum, are often confused with warts. Pearly penile papules. How many of you guys know about pearly penile papules? Some do and some don't. This is always the distribution of pearly penile papules. The most beautiful name attached to almost any anatomic part. And it's always along the coronal rim here. It's not always uniform and symmetric. You can see areas where there are some and where there aren't some. But it's important to know about these and to be able to tell patients that these are normal and to name them. So think of lovely pearly papules, and you can name them and say these are normal. We can see some more here. They're a little bit more profound. And then these lesions here, they're not really lesions. These bumps that we can see here, where the median raphe becomes the frenulum and meets the glans penis. And actually these are really nice because they're so symmetric and they're so profound. But these are called Tyson's glands, and they're also normal. Now, I don't know if boxers have them, and I don't know that they're associated with chicken production. But whatever can make you remember the name so that you can name them for the patient and say that they're normal and never treat them for warts. This is an exquisitely painful area to treat and shouldn't be. Then there's no reason to do that. The tiny fine bumps that we can see here, this is called lichen-niditis, and this is important to know about because this is easily mistaken for warts. And in fact, he probably does have a couple of warts up here at 10 o'clock. But the uniform bumps here are a little bit shiny. They're a little paler, but they tend to be the color of the background skin. Vestibular papillae, and I actually had an image from New England Journal of Medicine forwarded to me about vestibular papillae. She was diagnosed by her physician as having genital warts and sent to dermatology, and she went in because she was having itching and burning. And he said, "You have warts, you have these bumps, this isn't the same person." The dermatologist went, "Oh, this is such a great teaching moment. You don't have warts, you have vestibular papillae." But vestibular papillae are not pruritic. They don't itch and burn. You don't have to scratch them. And she actually had lichen sclerosis atrophicis, as well as her vestibular papillae. But she didn't need treatment for warts in any case. Fordyce spots, which are just sebaceous glands. People have them along the edge of the lip too, at the vermilion border. And we can see them because we're seeing through the epithelium. It's stretched thin, so we're looking through it. If you push that together and make it thick, you can't see these any longer because the skin is too thick, so we know it's under the skin. And they're actually normal as well. So your homework when you leave, in addition to kind of looking up lots of conditions on Google, is to go in the restroom and stretch your lip and see if you've got any of these along the margin there. Angiomas, look how much like a wart this looks. But it's not a wart, and we can tell partly because of the distribution on the lateral aspect of the urinary meatus, but also because when we compress this, it blanches and then it'll refill, so it's clearly vascular and it's very soft. More molluscum contagiosum. This kid actually had been told that he had herpes because of the erosion down below, but we have seen people that have been diagnosed as warts who actually have molluscum contagiosum, a different viral infection, very benign, but of concern, obviously. And scabies, not my image. If anybody called these warts, something would really be wrong with them. Basal cell carcinoma, which brings up Happy Halloween. When to consider a biopsy. How do you know when to consider a biopsy when somebody's got external warts and external bumps? Well, basically, if they're an elderly person, I don't know what elderly means anymore, but anyway, if you've got something that's looking particularly abnormal and worrisome, if it's got a change in color, then it's worth taking a sample to make sure that it's not something pathologic. If it's bleeding really easily, that can be a concern, and it's worth being evaluated for, or if it's ulcerated, or if you've been treating and it's not getting better. But make sure if you're treating that you're treating adequately to begin with. We've had lots of people sent to us who have had inadequate freezing. They've been frozen, but it just has been the top, and they didn't get down to the growth layer, and so the things have persisted. This is boinoid papulosis, or squamous cell carcinoma in situ. An abnormal color, didn't go away, not associated with itching, just sort of found. This clearly looks abnormal, and you absolutely would send this. I wouldn't even know what to make of that in terms of it being wart related. And this would be clearly a no-brainer. You'd be thinking about melanoma with that. The treatment remains elimination of the worrisome bumps. And you can do that either patient applied, provider applied, or watchful waiting to see if they don't eradicate them on their own. In terms of messages to patients, I say limit trauma to the area. The worst warts I've ever seen were in a woman who thought that they were unclean, so she used a vegetable loofah thing to try and scrub. And she ended up with warts from her mons pubis through the vulvar area, in the perianal area, up into the gluteal cleft because she spread them. We actually had a kid with eczema this week on Monday who had an itchy spot, eczema, itchy spot on his penis, used a brush to abate the itching, and has herpes everywhere. Everywhere. Well, warts can do the same thing. If you were going to spread and inoculate, we want to treat that skin gently. If they've got an underlying inflammatory condition, fix it, because when the skin is healed and it's not trying to heal itself, then it slows down things. You probably all know about patient-applied prescriptions that are available, and then there are provider-applied, and they all, at the end of 6 months, for some reason, seem to have a similar efficacy. And that probably, I used to tell people, well, by the time 3 or 4 months have passed, we'll be winning the war, because we thought we were winning. And in fact, probably their immune system finally was kicking in and they were beginning to have those involute on their own. The CDC treatment guidelines allow for all of those. The comparisons tend to be about the same. But again, the treatment goals remain limit the symptoms, limit trauma, and then for prevention, just to have your patients not have sex. Just kidding. We're going to talk about immunization because that's what's really, really critical. Limiting numbers of partners, condoms, and lubricants with condoms to avoid dry condom sex, which would cause tissue trauma and enhance transmission. Those are the big things. But vaccination at an early age. And I will tell you in closing that I asked my neighbors, in our neighborhood, it's a tight community. It's a cul-de-sac on 2 streets and several others. It's a couple blocks of cul-de-sac neighborhood. So all the kids belong to all of us in a fashion. And I asked my neighbor, have you had the kids vaccinated, the girls vaccinated? And she said, no, it really hasn't been around long enough. And Carrie's off at college. She went to university this year. This was last year when she was getting ready for university. And she said, besides, they only hang out with nice kids. So I know that I'm preaching to the choir, but even if you have somebody who never had sex at all, what if the perfect person that they fell in love with went through young and dumb and is perfect now, and they contract HPV from that perfect person? We want to prevent that. We want to minimize the likelihood of oral warts and lesions. We want to minimize the likelihood of anal warts and lesions. And you know, the vaccine recommendations now do recommend that insurance cover the cost of men who have sex with men up to age 26, just like for women. But it's recommended that it be covered with insurance to prevent the fallouts from those things. So your next speaker is going to talk about prevention with vaccine a lot more, so I will yield the floor to her, and I will thank you.